Well, welcome everybody. Good to see so many people for our data series. I think we're up to 38 participants. I think we can get started. Amelia, I'll turn it over to you.
Good afternoon, everyone. Thank you for joining our first summer series, first installment of the summer series in big data. We will have 3 of these. Today is the first one. We'll have one in July and one in August. Please stand tuned.
Hope you this.
Hold on. Hello.
Yeah, you're back on.
Okay, it says I was muted, but okay. Anyway, so this is the first installment in our Hopkins of Health, Business of Health summer big data summer series. This is the second summer that we're having this, and we're gonna have 3 seminars this summer. Today's we'll have one more in July and one more in August. Stay tuned for the announcements. And today we are very happy to have Kelly Anderson, Mark Meiselbach, and Frank Shu, who will be talking to us about the Medicare Advantage data that they have been working, which is actually at Hopkins. So with that, I'm gonna turn the floor over to Kelly, Mark, and Frank. And go ahead, you have 45 minutes, and then we'll have some Q&A.
Sounds great. Thanks so much, Amelia. So I'm gonna go ahead and share my screen. All right, so we're going to be talking today about the Medicare Advantage Data Lab and several of the data assets that have been aggregated through that data lab with HBHI. So we'll walk through just a little bit of background on Medicare Advantage, as I know folks on the call may have different levels of familiarity with that aspect of Medicare, and then talk specifically about the Medicare Advantage encounter data, how individuals affiliated with HBHI can access it, both in its raw form and in a cleaned up summary file that we're creating. And then walk through an example of a research study that leverages this data to hopefully prompt ideas for other work. And then I'll turn it over to my colleague Frank, who's going to talk about the public use files and how those are made available for HBHI. And then finally, we'll have Mark talk about provider directory data and then talk about some work he's conducted pulling together the public use files and the provider directory. Feel free to stop us at any point with questions. We'll have questions time at the end, but also happy to have this be a conversation throughout. All right, so let's talk a little bit about the changing landscape of Medicare Advantage. So beneficiaries in Medicare each year have to select either fee-for-service coverage or Medicare Advantage coverage. And so with Medicare Advantage coverage, these are Medicare Advantage plans that are funded by the federal government, but they're administered by a private insurer, like United or Humana or Blue Cross Blue Shield, or we have one here at Hopkins. And so the Medicare Advantage insurers receive a capitated per member per month payment from CMS to cover the medical needs of their employees. And so they're incentivized to try and improve the quality of care, but also reduce the total spending on care so they stay below that capitated per member per month amount. To do this, they typically develop contracted networks of providers where a beneficiary can go and see nearly any provider. In order to have lower out-of-pocket costs, they have to go see one of these in-network providers. And the Medicare Advantage insurers also have additional tools that they can use to manage spending and utilization. For example, prior authorization that are not available within the fee-for-service. And in trade-offs for some of these additional restrictions and controls that the Medicare Advantage insurers apply, they cap beneficiary out-of-pocket costs and often offer additional supplemental benefits. And so we have these 2 very different forms of delivering Medicare with fee-for-service or Medicare Advantage. So Medicare Advantage enrollment is growing rapidly. Back in 2005, about 13% of Medicare Advantage enrollees were Medicare beneficiaries were selecting Medicare Advantage coverage. But as of 2021, that's risen to 42%. So we're really now talking about a large portion of Medicare beneficiaries who are getting their insurance through this semi-private model. And CBO is also projected that by 2030, this is going to grow to about half of Medicare beneficiaries. So it's increasingly important to understand how care is being delivered and financed for these enrollees. Yet there's really limited evidence on the effects of Medicare Advantage coverage. There's a couple of studies in the published literature that show that Medicare Advantage enrollees receive higher quality or more efficient care for very specific clinical circumstances. For example, for post-acute care, for hospital admissions and mortality, around opioid use, and for Alzheimer's disease. But then several other studies show that Medicare Advantage directs beneficiaries to lower quality providers, including for nursing homes and home health agencies. More broadly, there's just no unified understanding of under what circumstances MA provides higher quality or more efficient care versus not compared to fee-for-service. We know that variation exists between Medicare Advantage plans. I think, one of the recent and high-profile papers on this was from Meiselbach et al., showing very wide differences in mortality for beneficiaries who enrolled in the lowest quality plans relative to the highest quality plans. And then we also know that there's several different mechanisms that insurers may use to manage care. For example, developing provider networks, by using different ways of paying and reimbursing providers through tools such as prior authorization. But there's really very little understanding of exactly when these tools are being used, how they're being used, how effective they are. And most of the existing work is descriptive. So there's really a lot more to do in order to understand the effects of Medicare Advantage coverage. So that brings us to one of the exciting new data assets we have here at Hopkins with the Medicare Advantage encounter data. But before I dive into that data, I just want to see if there's any quick questions about the way the Medicare Advantage program is structured or any of the background so far.
I have a question.
Sure.
So I'm actually, I apologize in advance. I don't know about Medicare Advantage so much. So I wanted to know if the patients they have economically advantage, they have higher income, or can you explain how they, I'm trying to figure out if there is a causation and causality here. The higher income patients actually categorize them, they choose the Medicare Advantage compared to the others. Thank you.
Yeah, that's a great question. So historically, Medicare Advantage enrollees have been considered healthier and wealthier, but as we see more and more Medicare beneficiaries selecting Medicare Advantage coverage, some of those gaps are shrinking. And then in recent work coming out, Brown from David Myers and colleagues, they show that the changes in Medicare Advantage enrollment have been predominantly for Black individuals and Hispanic individuals. But overall, I would say MA looks a lot more like fee-for-service than it did 5 or 10 years ago.
Thank you so much.
And Mark and Frank, I'm realizing I can't see the chat on my screen, so if any questions come in over the chat and you want to make sure that feel free to raise those as well. All right, so let's talk a little bit about the data.
So John asked if Medicare Advantage does not have age bracket pricing versus Medigap.
Yes, so sorry, what was the first part of that question?
John, are you able to speak? Do you want to ask your question, or?
My question was about Medicare Advantage. As I understand, it does not have age bracket pricing, so it's kind of fixed pricing, where Medigap for traditional Medicare, original Medicare does. So as patients get older, they're more likely to transition to Medicare Advantage. Is that correct?
So you're correct that Medicare Advantage doesn't have any like age or risk-based pricing in terms of setting the premiums for it. I've heard conflicting things about which direction people tend to go in because you typically don't have that supplemental insurance with Medicare Advantage as individuals get sicker. Historically, they've transitioned back to fee-for-service. But given the same clinical profile, I don't know if based on age they tend to move into MA or not. That's a really interesting question. All right, so let's talk a little bit about the data. So the Medicare Advantage encounter data is administrative data, very similar to the fee-for-service claims data, if you've ever worked with that, or market scan data, or any of those large administrative data assets. So through HBHI, Dan led the purchase of Medicare Advantage encounter data for 2016. And 2016 was the second year of Medicare Advantage encounter data that has been made available, and it's a little bit cleaner than the 2015 files. So for the 2016 data, we have carrier data, which is the provider office location data. We have hospital outpatient data. We have inpatient data. We have skilled nursing facility data, and we have home health data. And so for all of these files, other than the carrier file, we have 100% of claims for 100% of enrollees in Medicare Advantage in 2016. Because the carrier file is the largest, CMS actually won't release the full file. And so for that, we have all of the claims for 65% of Medicare Advantage enrollees. And that 65% sample is about 11 million Medicare Advantage enrollees, and it is considered nationally representative. And then in addition to that data, we also have both the fee-for-service and Medicare Advantage hospital data from 2016. We have a longer ranging set of MedPAR data. So MedPAR data is basically inpatient summary files. And we have that for both fee-for-service and Medicare Advantage for 2014 through 2018, enabling more longitudinal studies in the inpatient setting, as well as validation of the more detailed inpatient encounter data. And then finally, we have these master beneficiary summary files that include a lot of beneficiary demographic information from 2014 through 2018. And so this is one of the big data investments that HBHI has made. But as partner with this, the Johns Hopkins Drug Access and Affordability Initiative, led by Jerry Anderson, has also purchased a large set of fee-for-service claims data. So we have all those same companion files on the fee-for-service side that we have on the Medicare Advantage side, but for a longer period of years to really enable us to look at Medicare Advantage versus fee-for-service patterns of care, utilization, et cetera. And then in exciting news, we're going through the process of getting the 2017 and 2018 Medicare Advantage encounter data. And we expect to have that on our server system sometime around September. So the Medicare Advantage encounter data, as I mentioned, are administrative data. And so they include claim line level details about procedures, utilization, diagnosis codes, providers, et cetera. The key difference from the fee-for-service claims is that they do not include payment information. So because these are private insurers, CMS considers that payment information to be proprietary and does not collect it from the insurers. So it's not available for any kind of data. For these Medicare Advantage enrollees, we do have a lot of information about the demographic characteristics of the enrollees. So we have age, gender, county of residence, as well as information on the plans they're enrolled in, including the contract ID, which really tells you which specific insurer, and the plan ID. And these pieces of information can be linked to outside files that give us a better sense of how that plan is designed.
Kelly, there's a question from Jody. She's asking, what does it look like when beneficiaries come in and out of MA and fee-for-service?
Absolutely. So the beneficiary information we have is structured at a by-month level. And so we can see for each month whether they're enrolled in fee-for-service or a specific Medicare Advantage plan, or whether they've switched to another Medicare Advantage plan. And because we have both the fee-for-service data and the Medicare Advantage data, we can track their care and utilization across those different programs. So as I mentioned, these data have only recently been made available, which is why, on the earlier slides, I said there's so little understanding of what's happening with Medicare Advantage right now. So the 2015 data were the first data made available to researchers, and those were made available 2 years ago. The 2016 data became available last summer, which is when we purchased those. And then the 2017 and data are only recently available, and we'll have those in hand soon. Because these data are so new, there's been very little work in the academic space using these data. There's one study coming out of Brown, and then one where Aditi was one of the co-first authors on this, looking at the concentration of physician services during her time at ASPE. But there's really just a wealth of questions that we can answer, and there's not a lot of competition in this space right
Kelly, there's a question from Matt. He's asking if you could talk more about outside plan detail linking. So, we have network data, and he's asking if there's any premium benefit design detail that are linkable. I think that's, what we are talking about in a
Yeah, so I was gonna say, Matt, let's hold on that one for just a little while, because Frank's gonna go into more detail about that later on in the talk. But great question, and these are the things we're thinking about as well. So the Medicare Advantage encounter data have a couple of challenges that we don't typically see when we're working with fee-for-service claims data, particularly some of the older files, like the 2015 file, have known issues with some missing values and missing records, and these are not missing at random, they're missing in pretty systematic ways. So many of the insurers have missing claims that are concentrated in the post-acute care setting. So for example, those home health claims, we just know that a lot of beneficiaries who are getting home health care, we don't have a complete documentation of that care. And then at the provider level, the fee-for-service information has lots of detail about provider specialty, and we simply don't have that in the 2015 or 2016 data. Similarly, the provider NPI is poorly populated in 2016, but we do consistently have information on provider organization, whether that be physician practice group or a hospital affiliation. And so some of these issues are, getting better year over year. I think we're all excited when the 2017 data and 2018 data come in to see if many of these types of missing records are no longer a problem with that newer data. But certainly something to be helpful to be aware of if you're planning to look longitudinally across some of these years. And then we also cannot compare spending between fee-for-service and MA because, as I mentioned, we don't have payment information specifically on the MA side of things. And then to the question that was asked earlier, so we also know there's huge issues with selection, that our beneficiaries who are in MA differ in both observable and unobservable ways from their counterparts in fee-for-service. These differences are decreasing over time, but certainly, just head-to-head comparisons can sometimes be challenging because of these differences in beneficiary characteristics. So if you're interested in working with this data, we have the raw claim line level data, but this access to this data is heavily restricted by CMS. So we keep this on a secure server. It's currently hosted by the Drug Access and Affordability Initiative, and it requires completing a DUA and joining the IRB in order to access this data. So if you're interested in this data, I think the best first step is to reach out to Jamie and have her add you to the Medicare Advantage Data Lab listserv, and then we all can work with you on the DUA, IRB, and computing requirements. And then in exciting future plans, HBHI in partnership with the Head Center, in particular with Matt Meiselbach, are working to move this data over to a different server that will have a little bit more easy access for individuals who are interested in this raw data. So I mentioned that we have pretty stringent DUA and IRB requirements. So right now we have an IRB that's approval that's really focused on the effects of enrollment in Medicare Advantage versus fee-for-service coverage, and includes several different categories of questions under this. So really trying to understand what MA means for patient clinical outcomes, particularly for vulnerable patients, to compare the effects of Medicare Advantage versus fee-for-service coverage, particularly in clinical context with extensive needs, including physician-administered drugs, emergency hospitalizations, elective surgeries, and end-of-life care. So if the kind of question you're interested in falls under the scope, we can add you to the existing IRB and DUA. But if not, we simply need to file amendments to make sure that the broader scope of questions are being covered. So we also recognize that it can be a learning curve to work with those raw claim line level data. And so Chris Roebuck, as part of the MA Data Lab, is working to create a summary file where the real goal is to support pilot projects. So the summary file is going to have measures of enrollment, indicating someone's continuously enrolled, or to Jody's question, if they're switching from one year to the next. Provide flags for comorbid conditions, all the common ones we see in Alex Hauser and the chronic condition warehouse, as well as utilization, for example, at a beneficiary level, the number of PD visits they have each year, the number of inpatient hospitalizations, et cetera. And so the goal of this summary file is to enable HBHI affiliates to be able to quickly ask questions, such as how often does X condition occur for individuals with Medicare Advantage coverage? What % of beneficiaries with a certain condition are in fee-for-service versus MA? What types of MA coverage do beneficiaries with X condition or Y characteristic have? So are they in an HMO, are they in a PPO, are they in a special needs plan, et cetera? And so accessing this summary file will still require access to the restricted server, but by working with HBHI affiliates, hopefully this summary data will make it much easier to determine the feasibility of a project or get data to support a pilot grant application. So I want to stop there and see if there's any questions about the types of Medicare Advantage encounter data that we have, or characteristics of that data before I dive into an example using that data. All right, then I'm going to go ahead and dive in. So I use the Medicare Advantage encounter data as well as the fee-for-service data to look at the prescribing of low-cost versus high-cost physician-administered drugs in Medicare fee-for-service compared to Medicare Advantage. So just a little bit of background. So physician-administered, or what you sometimes hear called Part B drugs, are injection and infusion drugs that are administered in a clinical setting. So these aren't the retail pharmacy drugs that you go pick up at CVS or Walgreens. So fee-for-service Medicare spending on physician-administered drugs has risen substantially in recent years. It's over $32 billion a year, and it's growing about 9% a year and has done so for more than 12 years now. So this is a real growing area of spending and of concern, both the fee-for-service and then potentially for Medicare Advantage insurers. So these drugs are typically paid for through the capitated medical Part B benefit rather than the Part D pharmacy benefit. So in fee-for-service, these drugs are reimbursed based on average sales price of the drug plus a 4.3% add-on payment. What that add-on payment really means is that when providers select a higher cost formulation, they get a larger add-on payment, even if a lower cost similarly or equally effective drug is available. So there's a lot of work looking at the effects of this problematic incentive in the fee-for-service space, including several papers coming out of folks at Hopkins. And these papers show that in instances where a similarly effective low-cost drug exists, many providers or their provider practice group or their hospital outpatient department still choose to prescribe the higher cost option. So we see this for filgrastim, for intravenous iron, denosumab, several biosimilars. And specifically for intravenous iron, we show that providers who are subject to the capitated Maryland Hospital Global Budget System far less frequently prescribe the expensive formulation of IV iron. And so what I'm interested in is whether Medicare Advantage insurers who are similarly subject to a capitated payment are also better able to direct beneficiaries so they get the low-cost option. But it's not clear whether or not this will happen because Medicare Advantage insurers are not the ones actually making the prescribing decision, and so they would need to change provider prescribing. So I look at 3 research questions in this paper. The first is, are Medicare Advantage enrollees more likely to get a low-cost drug in 4 clinical scenarios where similarly effective drugs exist? The second, do hospital outpatient departments and physician practices that treat a higher share of Medicare Advantage enrollees more often prescribe low-cost drugs to those enrollees? And third, what are the potential savings to Medicare if prescribing patterns for fee-for-service enrollees align with prescribing patterns for Medicare Advantage enrollees? So the 4 clinical scenarios I look at are anti-VEGF agents to treat age-related macular degeneration, where we see the low-cost formulation costs about $73 per dose compared to over $2,000 per dose for the higher cost medications. I then look at the use of bone resorption inhibitors for osteoporosis and malignant neoplasms, where differences are about $800 for osteoporosis and over about $1,700 for malignant neoplasms. And then finally, 2 common formulations of intravenous iron to treat iron deficiency anemia, where we have about a $700 difference. So just to quickly describe the approach, I use that 20% random sample of the Medicare fee-for-service carrier and outpatient claims and the 20% sample of the Medicare Advantage carrier and outpatient encounter records. I focus in on claims and encounters that have a procedure code for one of the drugs on the previous slide. And I restrict my analysis to older adults, at least 65 years of age, who are continuously enrolled in either Medicare fee-for-service or a single Medicare Advantage plan, so I can cleanly attribute them to MA or fee-for-service. And finally, require that they reside in one of the 50 states of Washington, D.C. So I first look at an unadjusted comparison of fee-for-service and MA use of each of the low-cost drugs. I then look at it in a regression-adjusted context where I control for beneficiary sociodemographic and clinical characteristics and certain market factors, and then examine differences between and within prescribing organizations. And then finally estimate savings based on average price per dose for what fee-for-service could save if prescribing patterns align with Medicare Advantage. So getting into the exciting part, let's look at results. So what we're looking at here is the share of enrollees who are treated for one of these conditions who are getting the low-cost drug. So starting at the top with anti-VEGF for age-related macular degeneration. About 35% of our fee-for-service enrollees are getting a low-cost formulation. And that's compared to 58% of our Medicare Advantage enrollees. So about 23% more of our Medicare Advantage enrollees are getting the low-cost drug. That same pattern persists for each of the next 3 scenarios where our Medicare Advantage enrollees are more likely to get a low-cost drug than their fee-for-service counterparts. And then, here we're looking at this. So this is the coefficient on Medicare Advantage coverage, looking at the difference in probability after controlling for beneficiary sociodemographic and clinical characteristics, as well as county of residence. And we see that in each scenario, Medicare Advantage enrollees have a higher probability of getting the low-cost drug than their fee-for-service counterparts. So there's a couple of things that could explain this. Perhaps Medicare Advantage insurers simply select and contract with more efficient providers. And so they're just directing beneficiaries to providers who tend to prescribe the low-cost drug. Alternatively, it may be that providers are treating their Medicare Advantage enrollees differently than their fee-for-service enrollees. And we really do, yeah.
Mark, please go ahead.
Sure. Savannah in the chat asked if the higher cost and lower cost alternatives provide the same clinical outcomes, which would indicate that the differences in branding.
Absolutely. So I would say these are quite similar drugs. There's a whole lot of clinical evidence that underlies them, but we can consider them to be similarly equally effective with these scenarios.
And Thomas asks, how do you define dose from the claim? Are you using quantity by day supply, or what method are you using?
So I am simply looking at if there's a unique bill on a specific day and it has that HCPCS code, I consider that to be a single dose. But yes, there may be different amounts of units administered, and I don't account for that in the way I'm looking at this analysis. And so we do see these really wide differences or very large differences in prescribing patterns across provider practices and hospital outpatient departments. And so we see on the left-hand side in the lightest gray are the organizations that exclusively prescribe the low-cost formulation. We see many more organizations in the dark gray on the right-hand side that exclusively prescribe the high-cost formulation. And then the middle are organizations that prescribe a mix of the low-cost and high-cost drugs. So in blue, we still have that same county fixed effects model where we also control for all these beneficiary socio-demographic and clinical characteristics. But in red, I have a version where I instead include a fixed effect for each prescribing organization. And so we still see that even after we account for differences in which providers beneficiaries see, beneficiaries of Medicare Advantage coverage still have a higher probability of getting the low-cost drug than their fee-for-service counterparts. But we also see that the effects are a little bit smaller than our alternative specification of the model. And so this suggests both that Medicare Advantage insurers are directing beneficiaries to more efficient providers, but then even within those providers are more likely to give the low-cost drug to their Medicare Advantage patients. And so if fee-for-service prescribing patterns aligned with Medicare Advantage prescribing patterns, we estimate savings ranging from $10 million for iron deficiency anemia up to $272 million for age-related macular degeneration. And this represents 7 to 12% of the fee-for-service spending on each scenario. So just to quickly summarize what we find here, in 4 clinical scenarios where similarly effective physician-administered drugs exist, older adults with capitated Medicare Advantage coverage more often receive the low-cost drug. This finding was robust to controls for patient characteristics, county and provider organization, and is consistent with that difference in financial incentive in fee-for-service compared to Medicare Advantage capitated payment. And we see those estimated savings to the fee-for-service program ranging to 7 to 12% across scenarios. So this tells us that the current Medicare fee-for-service reimbursement system for physician-administered drugs is associated with wasteful spending. And since 2016, there are many more scenarios where multiple similarly effective drugs are available, particularly with the approval of biosimilars. So this increases the possible savings associated with the selection of low-cost drugs and heightens the value of policy options that decrease wasteful spending on high-cost drugs. But I would say more research is needed to really understand the mechanisms that insurers may use. And several of the next parts of this presentation will talk about some of the other data sets we can use to start to understand mechanisms. So I'll stop there and see if there are any questions before I turn it over to Frank. All right, Frank, the floor is yours.
Great. Thanks, Kelly. So as we've alluded to, I'm going to introduce our ongoing effort in building a repository of MA-related public use data. And we will also welcome feedback on other data sets that might be available and how we can make the data more accessible and useful for everyone. So could you move to the next slide? So as Kelly has said, Medicare Advantage represents a unique opportunity for us to study the relationship between health plan design and outcomes. The MA setting has the combined strength of private market and public program. We've got enormous variations in plan design because of insurer competition. And since it's publicly financed, we have detailed data in the public domain about all MA plans, such as their characteristics, enrollments, and quality ratings. And these data are linkable to the encounter data we just heard about and the provider network data that Mark is going to discuss. So with this project, we will be putting together some of the frequently used public data, and we want to reduce, by doing that, we want to reduce duplicate data collection and cleaning efforts and make it easier for people to study MA. So next slide, yeah. So for each year, we plan to assemble information at 5 levels that are linkable to each other. The most detailed level is contract plan county. There will be information that vary at this level, such as enrollments, premium benefit design, and what kind of plan it is. So as we can see in discussion window, there's a lot, still already some discussion about benefit design. The information can be messy, so we are still exploring what information we can conveniently include it in our public use data file. And at a contract level, we would have the type of contract enrollment at this level and contract star rating. And for each provider network, we will have measures of network breadth at the county level. They may capture the breadth overall, like percentage of covered providers and travel time to providers. They may also focus on certain physician specialties. And next, yeah, we would also put together county level MA penetration and county demographic and socioeconomic characteristics. Then for provider MPIs, we'll be collecting specialty utilization and charge information. And we will also pull some useful information from the OneKey database, such as address and affiliation information. And then we'll also be assembling the plan crosswalk so that we can track new plans, plan terminations, and consolidations across years. And so in terms of data access, we will have raw data and clean data stored on a server. We also plan to put them on cloud storage so that the access will be not restricted. Is there? Okay. So we'll also put them on cloud storage so that access will not be restricted by the DUA. So everybody, if you're interested, please sign up for our listserv, and we will keep you posted about our data sharing plan. And I'll just pause to see if there's any questions on this part.
Frank, so what is the timeline on this?
So right now we are working on 2019 data, and with that we are going back in years, and the current focus is the county plan county level and contract level files. So there will be the 2019 versions of these files will be available in the next few weeks, and in the future, we are going to add more years and more information. So, and we will be communicating that through the listserv.
Thank you.
Okay, with that, I'm going to turn it over to Mark, who's going to talk about provider network data and his recent work using that data.
Thanks, Frank. Kelly, I think you can just go to the next slide. So I'll be talking about the Vericred provider networks data. And I think that the slide kind of lays out everything about the data. It's a fairly simple database that's really just a directory of providers that are linked to networks. And there's a network plans file that crosswalks different plans to their specific network IDs. And then that file links to the files that Frank was discussing. It links to our MA data by this HIOS ID, which is a combination of the contract ID, plan ID, and segment ID. And then once we link the plan to the network, we can then link that network to all of the providers that are in the Vericred database as well as some information on the providers, including their location. And then once we, once we link to the providers, they have their NPI, and we can link that to all sorts of other databases with information at the NPI level. So I guess I'll ask if there's any questions about the orientation of the Vericred data before we talk about our research question using these data. Great. Okay. So here we study the relationship between network breadth in MA and plan quality ratings. And Medicare Advantage is a really great area to study this research question because MA insurers seek to balance their incentives to control costs that are rewarded by the capitated payment system with their incentives to deliver quality, which are rewarded by plan star quality ratings. And network design is one of the tools that they can use to manage costs, potentially by excluding high cost providers, or manage quality theoretically through excluding low quality providers and creating higher quality networks. But the relationship between network breadth and quality star ratings is theoretically ambiguous because on the one hand, narrow networks may achieve lower costs at the expense of consumer satisfaction, which would be associated with lower star ratings. But on the other hand, the narrow networks may be higher quality, have lower cost providers, and have higher star ratings. So in this study, we use the Vericred data plus these public use files to first describe the landscape of physician network breadth in Medicare Advantage and examine the relationship between network breadth and quality ratings. So as I mentioned, that we calculate network breadth using the 2019 Vericred provider network data, and we calculate a breadth measure as the percentage of total eligible providers in a county that are linked to the specific network. And we restrict the eligible providers to those that are in a specialty that are explicitly outlined in the CMS network adequacy criteria. And we require that they administered at least 5 services in the 2017 Medicare fee-for-service claims data. And we obtain Medicare star ratings from the 2019 CMS public use files. And our sample in total consists of roughly 84% of all MA enrollees. And the level of observation is that at the plan county level. And what's maybe helpful for everyone else to know here is that while this is 84% of total MA enrollees that are in our sample, the Vericred data have approximately 90% of all the HMO and PPO contracts that we restrict our sample to. You can go to the next slide. So we model the relationship between star ratings and breadth using ordered probit models, where we observe the star rating for each plan I in county C and state S. And this takes an observed value from 2 to 5. And breadth, as I meant, was there a question? Breadth, as I mentioned, is the percentage of county physicians that are in network. And we also control for the plan type, which is HMO, local PPO, or regional PPO, as well as a vector of county characteristics, state fix effects, and we cluster standard errors at the contract level. So here we show the raw distribution of the plan county breadth. This is enrollment weighted plan county breadth. And on average, we find that 41% of providers in a enrollee's county are included in their network, and that approximately 1/3 of enrollees are enrolled in narrow network plans, which we define as having fewer than 25% of providers in their network. And here we show the state-by-state distribution of enrollment. I see there's a question about making the slides available. Yes, we should be able to make the slides available. And so here we show the state-by-state variation in the percentage of enrollees that are enrolled in these narrow network plans. You can see that there's a huge amount of variation. For instance, in Rhode Island, almost no one is enrolled in these narrow plans, whereas in some states like Kansas, it's well over half of enrollees are in narrow network plans. Next slide. And here we stratify our sample by those enrolled in narrow versus non-narrow plans. And you can see just in the raw data that there's there's some evidence of a relationship between network breadth and the average star rating. The average star rating in narrow plans is 4.12 compared to 3.75 in these non-narrow plans. And the difference is really concentrated in 4.5 and 5-star plans, with just over 50% of narrow enrollees in plans with a 4.5 or higher star plan rating, while it's only around 10% in non-narrow plans. And so here we show the results from the adjusted and unadjusted ordered probit models, where we regress the star rating on breadth, and we include specifications with the Kaiser plans included, which tend to have very narrow breadth but high star ratings, and we include adjusted and unadjusted models. And what are shown here are the coefficients on plan county breadth with 95% confidence intervals. And the coefficients represent the probability change in having an increase in star rating given a 1 percentage point increase in breadth. And we see that in all specifications, narrower breadth tends to be associated with higher star ratings. And so this first, the last breadth measure we showed you was including all specialists in one metric, but here we break it out and calculate 2 separate metrics, one for primary care doctors specifically and one for all other specialists. And we find that this relationship that we observed in the previous slide is almost entirely driven by the relationship between star ratings and the breadth of primary care networks. And the red line here shows the coefficient from the same models in the previous slide that include Kaiser plans as well as adjusted for covariance. And then we further break this down to look at the relationship within HMO plans or PPO plans. And we find that the relationship tends to be much stronger in HMO plans, which perhaps is consistent with our expectations. These HMO plans keep costs low, typically by routing patients through a narrower set of doctors, often using a certain primary care doctor as the gatekeeper to their access to specialists. And so we see that there's a stronger relationship between breadth and star ratings in these HMO plans, and specifically among primary care doctors. And here is a pretty preliminary look at the potential mechanisms that are driving this relationship. We're still digging into this, but one of the hypothesized mechanisms that we've thought of is that narrow networks may have more integrated, higher quality networks, resulting in these higher star ratings. And so in this case, we would expect narrower networks to be associated with higher levels of integration and higher hospital quality, and for these metrics to be negatively related to be positively related with star ratings. However, from an initial look here, we look at the pairwise correlation coefficients between each of these metrics, and we do not find our hypothesis relationship so far between our breadth measure and the level of integration or hospital ratings. And so this is something we're continuing to dig into. So to quickly wrap up, we find that there's huge variation in enrollment in narrow network plans, and that roughly 1/3 of Medicare Advantage enrollees are in these narrow network plans, and that the narrow plans are associated with higher star ratings, with most of this relationship coming from primary care network breadth as well as HMO plans specifically. And the mechanisms remain unclear, with no evidence so far that it's being driven by integrated networks or higher hospital ratings. And so we're continuing to look into those potential mechanisms and finding a better way to measure those metrics. I saw that there's one question. Do we want to address that now?
And Maura, do you want to ask your question? Unmute.
Yeah, sure. I was just making a comment, wondering if, in terms of any studies done with this data set that look at risk-based normalization, just whether the data set should be footnoted for some new interventions that we're making in our Johns Hopkins medicine population around just diagnosis capture, HCC risk adjustment stuff.
So I'm personally not aware of anyone incorporating that in this network's work. It's one of the things kind of on our to-do list as well to try to capture enrollee risk across these plans. But yeah, I'm not aware of any broader literature on this topic. No.
Yeah, I mean, there's a real opportunity because these, kind of national encounter data are fairly new to start to apply these things. I think we're from the encounter data side, we're still making sure we, kind of trust the quality of the data before moving on to that, some of the things you're suggesting. But I think that's going to be really important down the road, and it'd be great to work with groups that, have kind of an inside, attachment to that, because they're, like Hopkins is running a Medicare Advantage plan. But I think that kind of stuff is hopefully, around the corner for us.
Great, thanks.
So yeah, so that this just last is to direct people to those that they can reach out to with questions or comments. Dan is leading us in this MA Data Lab. You can reach out to Kelly, myself, or Frank. Other faculty included are Lauren, Nicholas, Eric Slade, Aditi Sen, Ya Kosa, Antwi, Mike Darden. And then, as Frank mentioned, you can reach out to Jamie if you want to be part of the listserv about various things we have going on and when data become available. So we'll open up to questions at this point.
Hey, Mark, I had a quick question for you about the Vericred data. For which years is it available, and how would you go about accessing that? Is that part of the cloud public use data that Frank talked about, or is there some other procedure?
Yes, so you should be able to access it through just cloud storage. I don't think that there's any specific DUA needed to get you access to it. In terms of the years of data, we have 2019 and 2020, but the data can sort of change a little bit year to year. Vericred is continually kind of improving its process of data collection, which for us is sometimes not convenient because the data can change year to year. So far, we've just mainly focused on 2019 to keep it consistent, but I think there's opportunity probably long-term to build out more of a longitudinal sample of the data.
And I'll just say, it'd be pretty easy to download it, but Mark and myself and a number of others have been working with these data for a long time, and there's just so many quirks to it that connecting with other users. I think that's somewhat what we're trying to create here is an opportunity to connect with other users to share knowledge about some of the ins and outs of these data, and so we could just put on a server and send it to you, but I think I'd recommend just connecting and kind of talking through what you want to do, and we can very quickly tell you what the holes are and what the opportunities are as well. But I'd be happy to follow up with you.
Awesome, thank you.
I'll just say as just a broad comment here, and some of the rationale for making these investments and putting in the time and effort and getting to know these data is, if you have done health services research or you're interested in diving into it and you go to the literature, there's like thousands and thousands of papers a year really using the fee-for-service Medicare data. Going on for 20, 25 years. Medicare Advantage is 40% of Medicare. And there are like dozens, accumulated over all years in Medicare Advantage. So the the newness of these data and the unanswered questions in MA and the importance of it, given that it's 40% and growing, and the connection to this kind of the other way of operating this public program on Medicare through private payers who who offer more restricted provider networks, and bringing all those data together really, I think, is just a tremendous opportunity to be on the early adopters of these new data sources, and we can kind of do this together and really become national leaders in informing policymakers, payers, consumers about the pros and cons of MA with respect to traditional Medicare and MA plans with respect to each other. So that's really why we're all kind of putting in so much time and effort, not only for our own projects, but also for trying to create a community around it. I just want to thank Mark and Frank and Kelly for all the work that they've done on this project, and Chris as well, and all the things that just really diving in not only for their own work, but for trying to develop some community benefit here. Don't be shy, everybody. It's time for questions here.
I have a question, if I may. Actually, I'm not very familiar with the Medicare Advantage, so I apologize if my question is very actually simple. But I wanted to know if you have categorized the patients separated, like for example, patient with kidney disease. Just focus on a specific type of patient population, and then compare these drugs. So I know that you have like limitation with the data. You can't go for look for causality and all the basically econometrics actually things to figure out exactly what is going on with this Medicaid Advantage patient. But I think that definitely there is a selection bias here, and from the beginning, and in some way we can actually figure out who are those patients. If you don't have access to their demographic information, probably we have to look at their chronic diseases, since, like, for example, patients with kidney disease are very expensive in our country. So that's just a question, because I'm working with a patient with kidney disease. Thank you.
I'll try to take that one, but I'd like to hear from others. I mean, I think it's so important what you're bringing up. There's so many things packed into it. I guess first off, there's new programs in Medicare Advantage for kidney disease, because it's so expensive, and the way you pay for Medicare Advantage is through a capitated payment, so you have to get the kind of risk adjustment right. But for the most part, like, MA plans want to totally avoid ESRD patients, and so they're coming up with new ways of designing an MA plans to address them. It's kind of emerging. So I don't think we're at a position now to evaluate in type of with identification this policy change, but we can be, because 2021 data aren't really available, but there's a lot that I think at this point it'd be descriptive, like what plans are available, what are there in the plans, can we say anything about enrollment for these plans? I think that's like the state of the science. I'm afraid there are other projects, and I know Lauren has a project that's really trying to look at causal inferences with MA and trying to use some of the instrumental variable techniques that have already been in the literature to look at that, and she could speak to that a little bit. I don't want to put you on the spot, Lauren, but do you want to add anything?
Sure. I mean, I think MA is no different from any other kind of insurance choice paper where we're going to worry a lot about selection, and a pretty big chunk of the MA literature, especially the earlier literature, has been trying to kind of resolve these patterns. And so there are a few instrumental variables that are kind of well established in the literature that people often use. There's also work, including some stuff from my dissertation a long time ago, using other information about kind of non-deferrable health conditions as ways to get some estimates of what's truly coming from patient selection versus plan effects and differences in care and healthcare utilization. So I think it's both an area where we have some ways of dealing with this, but there's also definitely potential for more methodological innovation. But I don't think those selection problems like stop us from being able to do this work or anything.
Okay, I got a question, and can I? All right. I'm on faculty at the Uniformed Services University. For those of you who don't know, we call it the School of Medicine for the military. We have TRICARE, so our population is, it's TRICARE based, and we have those who are over 65. They are called TRICARE for life. So basically, some of those beneficiaries, they have Medicare and TRICARE, and TRICARE is the pay of last resort. Since I joined here, I've heard a lot of assumptions in terms of cost and utilization for that population, but really nobody knows. And part of that is no one has been able to kind of match TRICARE data with Medicare data to sort of complete any meaningful analysis on those beneficiaries. So I'm wondering if there is a way that we may be able to sort of combine, merge the data on this very important population and costly population for the military. Over. Thanks.
Well, I mean, I know I speak for all of us where we'd be like incredibly enthusiastic about collaborating there. Everything you said, just like, you're preaching to the choir here. We'd love to connect, and maybe we can find a time to follow up. I don't know if other people have much to say in addition to that, but I'm sure that that others would be enthusiastic about connecting.
Mm-hmm.
Yeah,
so how would you like to proceed? Oh, go ahead. I'm sorry.
Yeah, that's great. I think we will be really just second what Dan has been saying. The Indian Health Service is another place where there are a bunch of in a similar situation where they are the payer of last resort, and so I've been trying to lead an effort to merge their files to the CMS files, and it's incredibly complicated, but I think there's great payoff to doing these kinds of exercises. So it would be fantastic if we could try to figure out a way to do that.
Okay, that's great. And how would you like to proceed? Do you want me to contact you, or?
Yeah, just you can send me an email or write through Jamie, and we'll find a time to connect.
Sounds great. Thank you.
I had one more question, and if this needs to be handled offline, totally happy to do that. But what's the right way to think about collaboration with the restricted access data? Does the only person needing to work with the data directly need to go through the DUA and authorization process, or do all collaborators on the project need to do that?
Kelly, do you want to?
Sure, yeah, happy to take that one. So anyone who's going to be looking at the data itself obviously has to be on the DUA and IRB, and anyone who's going to be looking at non-aggregated results needs to be on the DUA and IRB. If there's a co-author who's weighing in on other parts of the work but isn't going to be getting into the nitty-gritty of the data, I think it's typically all right if they're not actually going through the DUA process.
Great, thank you so much. Really appreciate this presentation.
I think we're at the hour. Please feel free to follow up with any one of us if you have any other questions. Amelia, any final thoughts?
I just would like to thank Kelly, Mark, and Frank for a fantastic presentation. And again, if anyone is interested in the Medicare Advantage data or any other collaborative efforts with us or wants to present on their own project, big data, then definitely let us know. And just to put a plug in for the next seminar in this series, we will have Dan talk about provider data on the 23rd of July, I believe. So that will be our next installment, and we're very much looking forward to that. So thanks everyone for joining, and do let us know if you have any ideas, suggestions, or short speeches. We're happy to read them. Thank you.
Thanks for organizing this, Amelia. Bye, everybody.
Thanks.
Thank you.